Okay, so to kick off the panel, I want to kind of get a lay of the land of just what the barriers are. So traditionally in medicine, we have this idea of kind of the gold standard of evidence. For drugs, it's a randomized control trial. A bunch of people get a drug, a bunch of people get a placebo, we compare the effects, done. But this isn't really appropriate for digital health technologies. And I'm hoping to understand from you guys a little bit more why that is. Sarah, why don't you start?
Yeah. So very much, absolutely, the evidence generation piece is very different for digital health tools. Firstly, we need to see what we actually mean by digital health tools. So that covers a huge spectrum of different technologies. But rightly, as you said at the beginning, over the kind of COVID pandemic, we've seen a whole new kind of market of digital health technologies. And a lot of them don't have the evidence behind them. And as a doctor, and I'm sure many clinicians here in the room are very much familiar with that concept of evidence-based practice. Everything we do needs to have evidence behind it. If you're prescribing a drug, you need to make sure that it's got the evidence behind it before you give it to a patient. At the same time, when we've got digital health tools, we need to make sure that we've got the evidence for those as well. And there was a great study out last year, and it was done by Roche Health and clinicians at Johns Hopkins. And what they found over a review of like 250 different technologies, they found that only about 50% of them didn't have any kind of regulatory approvals, didn't have any kind of filing to the FDA, and didn't have the evidence behind them. So this is a huge problem, especially when we're kind of relying more and more on digital tools. We need to make sure that it actually says what it does on the tin. And this is what we mean about evidence. It's very different to what we would do for drugs. We can't do a randomized control trial for every single digital tool out there. It's not appropriate, it's too expensive, and the timeline is very, very different. So we need to think in a different way, have novel approaches to how we kind of deal with this issue.
Mm-hmm. Yeah. And then I guess we're using the term digital health technologies, but what falls underneath that umbrella term is obviously massively diverse. And I kind of, at the beginning of the panel, kind of want to get kind of a stricter delineation of what we mean by that term, and maybe Tamir, you can help us with that.
Sure. So I think you can make an easy distinction between digital-only products and digital and devices, and potentially digital diagnostics that Matthew can talk about more. But on the other extreme, you've got digital therapeutics, purely digital interventions that are there to treat patients for a given condition, and different digital products with different use cases would have different needs of evidence, and the safety requirements would be different, the standards would be different, and the efficacy that you expect them to get to will probably be different as well. Just the question about where do you set the standards for those kind of evidence, and how you think that the evidence should be generated, that would dramatically change between one set of products to the other. And you have to make the distinction between them.
Yeah. And I think it's also important at the start to kind of stake out why this matters. Obviously, like, we are all kind of relying on digital health technologies, maybe without even realizing, like our Apple Watches or whatever. But when it comes to this idea of there being this big barrier to evidence gathering, there obviously seems to be a multifold of problems. Number one, people can't get them approved, etc. And then number two, I think from the patient side, it matters as well. We don't want them to be using technologies that maybe don't work, or maybe even harmful. So I wanted to kind of put the question to the panel, why does this matter? What's at stake? Maybe Matt, you can start.
Yeah, sure. So I think let's just maybe spend a bit of time dissecting what we mean by evidence generation. Mm-hmm. So the way that we would see that is that there are two sides to that. There's evidence of safety, and then there's evidence of value of the solution. And there is a slight crossover, but broadly I think you can separate them like that. So when you think of any type of digital health solution, and I completely agree, it's an incredibly broad term, and it's actually fairly unhelpful. Some of those products will require regulatory approval, which you need to show that they're safe and that they work. And so it's really important to know what the intended use of that product is, because that drives what the regulatory classification is, and then that drives what you need to do in terms of establishing evidence of safety. Broadly, that breaks down into you need to establish clinical association, you need to do analytical performance, which is basically saying that the computer or the algorithm is calculating in the right way, and then you need to do a clinical evaluation, which is validation, which shows that the product is having the clinical impact that you are claiming. For me, that's table stakes, right? You can't actually bring a product into a healthcare system. No one is going to talk to you if it's not approved. Once you've done that, though, you then need to show that it has value to that health system. So the stakeholder for the evidence here is the regulatory body. I work all over the world, right? So that's the FDA, or we work through notified bodies in Europe, or we work through NICE and MHRA in the UK. When we think about evidence of value, it's a different stakeholder. Then it's a stakeholder who's going to be your customer, so who's going to pay for your product, and it's the user of the product, and that can be a clinician, or it can be a patient, or a combination of both. So there, they want to see different things. They just make an assumption that this is a safe product, right? But the customer, the person who's buying that product, wants to know that they're going to get some sort of return on investment. So they're going to need to see some sort of assumption-based financial model. And the clinician and the patient wants to see that it has value, that we talked about safety use, but it also has an impact in whatever we're claiming. So if we're talking about a digital diagnostic, is this more accurate than 2 pathologists or 2 radiologists looking at an image? If we're talking about digital therapeutic, does this intervention work better than other established interventions that already exist? So I think it's important to dissect down, and it is a complex topic for people to navigate. Maybe I'll stop there. I've much more to say, but I think that we have to level set.
Saira, what do you think?
I completely agree with everything that you said there. And I think it's kind of trying to frame what type of evidence are you looking for? Is it clinical outcomes? Is it financial? Is it, regulatory purposes? Or is it kind of the safety profile? Then you're kind of looking at who's this evidence intended for. Is it the payer? Is it the clinician? Is it the end user, who may well be the patient? And I think the really important thing then to look at is going to the what type of evidence you need to generate. Look at where the product is in the life cycle. So if it's that kind of early use stage kind of thing, is it more qualitative research that you need to do? Is it kind of user testing that you're doing? When it's for regulatory purposes, you probably need to do a clinical study at that point, and there's lots of different ways to do that. Then the reimbursement piece, it's more looking at the financial value, what's the return on investment being made there. And then it's the kind of post-deployment part of it, and then that's very much relying on real-world evidence. So it's kind of trying to parse the different, whether who the payer is, what type of evidence you're looking for, and also what stage of development that you're at. And that helps kind of break down the different pieces that you need and makes it much more simpler to try and find a plan to do that.
And then, Saira, I want to go back to you again because you're deeply involved in this because she has 2 startups, which I think is a bit greedy. And like we said, the pandemic kind of triggered this, cataclysmic change in the field. And from speaking to you before, you've kind of really noticed the change in when it comes to getting funding for your startups, what funders are looking for has really changed. Before, I think you said they would skip past the evidence slide. But now they're like, no, go back. I want to look at that again. So can you talk a little bit more how things are changing and why maybe that's a good thing?
Absolutely. And I think we all know the events in the last week, in terms of the contraction in the type of funding that's available, where that's available as well. So actually, everything is tightening, budgets are tightening across the board. And as innovators, we very much need to demonstrate that your product has value, whether it's all the different kind of types of value that we're speaking about. And a couple of years ago, pre-COVID, there was a different kind of market out there for funding. And certainly over COVID, it was, falsely exaggerated, and there was huge amounts of funding that were there, and what we're saying that we kind of went to investors and it's like, yes, here's our evidence, yet we're not really that interested. Whereas now, actually, with less money going around, people want to make sure that what they're investing in has it says what it does on the tin. And I think it's really important. And what we've noticed at Prova Health is early stage innovators are coming to us more and more asking, how do you actually do this? And it sounds very simple. How do I show that my product works? And it's that huge chicken egg scenario as well. If you go to a health service, they want to know, how does it work? Does it work before they can do any bigger trials? Whereas actually, how can you do that early testing to show that it does work? So it's that constant back and forth. And it's then being slightly more innovative about demonstrating that value. But huge differences in terms of like what VCs are looking for now in terms of that evidence generation early on.
Something that I think is kind of like a tension is that you guys are all obviously on the side that we need to be gathering this evidence. There are some people who maybe, in a for-profit market are kind of speeding past that, putting their technologies on the market perhaps before the evidence is there. And then kind of going back to the kind of the patient side of it, like what do you think is really at stake for people who maybe aren't aware of the kind of evidence needed to show that a technology works and are maybe using it and maybe, like I said, potentially being harmed? Tamir, can you talk about that a little bit more?
Sure. So I think it's a really good question, and the essence of doing a good job to generate enough evidence when you're that kind of startup company is to make sure that you can really make patients feel comfortable about it. And the way to do it is through the clinicians, because the clinicians probably would have to prescribe that digital therapy or whatever the product is. And that evidence has to be reassuring. It needs to basically say, yes, it's safe to be used. There's a minimal level of evidence to show that it does work and it does kind of, as Saira said, does what it says on the tin. But also, these are the benefits that you patients should be expecting to get. In the same way you think about what will it take to convince a patient to use certain medicine, you will have to go through something similar. And it's already kind of, there's a pathway and there's always a way of thinking about it, which is already quite there. But for digital, I think you do need to make patients, first of all, more aware that there is something out there which is digital, and it might not be what that patient was used to prescribe, even to treat the same condition. And I think you need to think about what is it that you as a clinician and as a startup company would have to do to make patients feel very comfortable about using something which is completely digital. We've seen in the Chancellor announcement last week that they're going to be about £300 million invested in mental health and some in MSK as well. It is happening, but the way to get us there would have to go through that kind of evidence conversation and getting the buy-in more broadly than just the evidence. What will it take? What other elements would patients would need to feel reassured about? Mm-hmm. And there's a lot about their awareness. There's a lot about kind of what is the right communication to those patients. How do you get the data? So, and we are still quite young as a system to get to those patients, but I think there's enough demand and there's enough supply there, and the trick is just to find the right balance to match them.
Mm-hmm. Yeah. So we've kind of sketched out, the problem and what's at stake, and maybe it's time to get to the more optimistic part. So, Matt, I know you're deeply involved in kind of the solutions side, both at Roche and beyond. So maybe you could talk a little bit about your work and where you kind of think the landscape is at the moment.
Yeah, so I think, the irony of the changing funding situation means that you're likely to see good startups, good companies emerge, right? Because they will be the ones with the evidence. They will be the ones that can show value. I think that that's a good thing. That means that the products are of quality and that they'll deliver value for patients, which is ultimately what we're all hoping for. I think where does the industry need to evolve to, as I think is a bit to what you were suggesting, is that if you have a clear path as a startup or any business for that matter to how you might generate some revenue from this product, then that is going to encourage people to make investments into you, because you're making a digital therapeutic or a digital diagnostic and there's a reimbursement code for that. Okay, well then it makes sense for us to invest in a study there. It makes sense for us to validate this solution. If that isn't there, then it becomes a much more difficult question. So if I had to say where I hope it evolves to, is that we now start to see reimbursement pathways for digital health emerging. And we are seeing that. So in Germany, there's DiGA, people may be aware of that. It's very specific for digital therapeutics. It's a very innovative policy, but I think we would all agree here that actually the implementation of it could have been done better, and there's a lot of lessons to learn from there. We'll see announcements coming out of France in the next month around reimbursement pathways. That's something that I've been involved in with an EU task force. And I think that other countries should follow suit. The US market's a slightly different kettle of fish, but there are some very interesting reimbursement codes from CMS around telemonitoring solutions. So they are actively exploring this, and CMS for those who don't know, Centre for Medicare and Medicaid, they have a digital health group that's looking at innovative policies. So where do I hope the future evolves to is clear reimbursement pathways, because if that's established, then it will be clear what evidence you need, and that will really drive the market further.
What went wrong in Germany?
I mean, that's a slightly controversial question in itself. Look, I think it was a super innovative policy, and it basically only covers digital therapeutics. So that has to be interventional. And if you think about it, actually, there aren't that many digital solutions that can be interventional. We're largely talking about cognitive behavioral therapies, advice for musculoskeletal conditions, right? So for those who don't know how DIGA works, basically what's interesting about it is, one, you can get reimbursed, but you don't have to generate your evidence up front. They'll give you a 12-month window in which you can generate your evidence. So that allows you to capture this real world data. The problem is just the practical implementation. So, and Sarah, I think you've written about this, so you probably know more than me, but none of the doctors know that these things exist. So they're obviously the gatekeeper on these solutions, right? So if they don't know that it's there, that's not helping anyone. The second is, they haven't really thought about not just the digital tool, but the digitalization of that process. So I think you have to print out a QR code, physically print it out, and then you as the patient can scan it on your phone, and then the solution emerges. And for someone, that's just not a good way to implement a digital solution. So I think they're learning lots, and actually the latest figures that I saw about 2 weeks ago show that there has been a further uptick, but there's a lot that can be done thinking about how we implement that better. And I also think, slight change of subject, but things like the NHS app library, where we had that infrastructure, and we had it first across the whole world, those things are how we are going to be able to prescribe the digital tools.
I'll just pick up on that point. I think Matt and Tamir have both made about clinician engagement. As a doctor myself, I'm a bit more aware of what's happening in the digital world, but actually most people don't have the time to know what to suggest to patients or what to say, this is really good to use, unless you've been deeply involved with it. So I think it's so important in terms of that clinician education piece for wider prescriptions. We're very, very good at that early stage innovation, but actually to take it to scale, I think the two things, like the reimbursement piece, but also making sure that we've got clinician engagement along the way, and they know what they can prescribe for their patients.
Yeah, for sure. And we've talked a lot about, how traditional modes of evidence gathering don't really work for these technologies, or at least aren't the best suited. I want to get into the nitty-gritty of what these maybe new novel types of evidence gathering might look like. And I know Roche was involved with a trial that I believe we used synthetic patient data. So that's one way, and there's real-time world monitoring, etc. I want to get into these different modes that maybe could be the future of evidence gathering in this sector. Matt, maybe could you talk a little bit about that?
Yeah, sure. So maybe again, just to spend a bit of time thinking about why it's a problem, right? So if you take a medication, a medicine, that molecule is working on the physiological system. If you're using a digital health solution, it's not working on your physiology, it's working on the health system. So the two things that emerge, right, is the first one is that health systems are different. So if you have a solution to prevent patients going into hospital, it turns out a fee-for-service hospital in Colorado is not that interested. So you've really got to understand how your product fits to a health system. The second thing is a molecule is it's a fixed thing, right? That is the molecule. It doesn't change. So with a digital solution, these things can be changed the whole time. I remember I had a startup previously, and I remember someone wanting some changes to the system. We went into the car park and coded it in the car park and went, oh yeah, we've just done the configurability. You can really change these things quickly. And so that creates a lot of challenges because it's not fixed. And so how do you test with our traditional mindset things that are changing all the time? And that's going to become even more acute with AI tools. So one of the things that you have to go through the evidence of safety piece, you have to go through the regulatory process. Some of the ways we've been experimenting there are using synthetic patient data. So instead of creating cases from real patient data, you can create synthetic images. For some of our software as a medical device, we use robotic testing. So we don't actually physically do the testing. We have labs that will test that, the different accelerometers and sensors and things like that. And then when it comes to some of the validation and the human factors work, we've been thinking about how do you deploy simulation techniques. So this is where you create a simulated near real world environment and you test the product in that. And we've had some really interesting insights from that. So it's really good for testing clinical decision support. It's really good for testing digital diagnostics because you can basically do A/B testing. You can control the environment much closer, so you can really test time and where people are looking on screens. We've tested mental fatigue and cognitive burden and how it actually impacts people's ability to make decisions. And you can set a gold standard, so you can really see, do they actually get the answer that we're hoping for? And at the moment, we've experimented with a number of different studies around that. And what we're now exploring is, well, can we actually use this as part of the regulatory submission? And for me, if you ask what the future is, those are the types of things that the regulatory bodies, the notified bodies need to start thinking about.
Can I come in on that?
Yeah, please.
So I think for the digital therapies in particular, I can see a direction of travel for real-world evidence to become very dominant in that space, which is probably different from what we were thinking about medicines back then, primarily because those startup companies, they've got a proof of concept, they've got a site or two within the NHS that they're working with, and you can see that the product is picking up. They're establishing some baseline based on those pilots and potentially a clinical trial. But then from that point, you almost like you want to stretch some sort of a baseline to say, yeah, I mean, that's reasonable enough to become a promising product. We can think that this technology is actually promising enough and we should offer this to patients and they should get reimbursement for that. And then the real-world evidence will basically fill that gap. And you build in the trajectory for where they should kind of be in terms of their evidence generation, let's say in the next 2 years. And when they get to that point, you can say, yes, did it fulfill the promise? Did it do what it was supposed to do, what we expected it to do? Did it generate the right evidence, the right clinical benefits as well? And if the answer is yes, then you know this was the right investment. Now, there's some kind of boundaries to that discussion. The first one is that you need to be able to reimburse based on the uncertainty that is involved. So it's not something that was tested for a significant amount of time. Therefore, you generally want to reflect it from a commercial point of view. And coming back to Matthew's point about that kind of reimbursement pathway, that's really crucial to get it right. So there is a kind of way of almost like saying, I need to, as a startup company, to be modest about the pricing to make sure that actually it's not a huge financial risk to the NHS or to kind of the other payers. And secondly, there is a need to kind of for the system to be able to use the right kind of HTA and evaluation. And we're working with NICE to kind of build that collaboration to make sure that that is the case. And we're seeing kind of a clear trajectory that is kind of to choose and prioritize the right set of products, the right technologies for what we think is the national clinical priorities. And from that point to start building those trajectory for these products.
Yeah. Final question. And I know, Tamir, you work on this, but it's encouraging that from a regulatory standpoint, it seems like people are starting to wake up to this kind of gap in knowledge. And I know, Tamir, that you work with NICE on kind of staking out a plan on how we're going to kind of fill that gap. First off, can you maybe define for people in the audience what NICE is? And then can you talk a little bit about what the collaboration looks like?
Sure. So NICE is the health technology assessor in the UK, in England. For those of you who don't know, they're doing the actual evaluations and basically with some of their kind of what they call the products. Basically, you could end up with something which is called a TA, technology appraisal and recommendation. And if you as a company would get to that point, and Roche is doing it quite frequently, then there is a mandatory funding for those products. We're studying now to think what does it actually look like for the digital area, and we're setting up a program which is called the early value assessment to get to those promising technologies that could be assessed, and they've got sufficient evidence, and we think that NICE thinks that the technology is promising enough, and therefore we're building now a collaboration with NICE to basically NICE will do the evaluation, and then NHS England will coordinate the kind of the rest of the pathway as a figure of speech, including kind of what adoption support might be needed, which we feel that some other countries have failed to get it right because they've really done a lot of good work to set up a quick reimbursement route, but as soon as those startup companies get reimbursement, they don't necessarily get to patients. So we think we can do something different, and the way to do it is to get through those kind of clinical channels and to find the clinical championship and to basically build the adoption in ways that actually make sense.
Okay, that is all we have time for. Thank you so much for joining me today and chatting through this. Thank you.
Thank you, Grace. Thank you, everyone.